Hello, everyone. Welcome to the Healthcare Improvement Scotland Personality Disorder Improvement Programme Learning System, and this is our second webinar in the series. I'll give an introduction just now. I think more people are still joining just now, but we'll do a bit of housekeeping, a bit of introductions as to how things are going to work today, and then we'll crack on. So we will be joined today by colleagues from NHS Highland and NHS Greater Glasgow and Clyde, and they'll be speaking about specialist services and integrated care pathways within those areas. The learning system for the Personality Disorder Improvement Programme is designed to give an opportunity to share local experience at a national level and to bring together a wide range of stakeholders with an interest in this area. And there'll be a further series of events, including workshops, continuing every 4 weeks, all the way through till March of 2023. Can I have the next slide, please? So for people who are not maybe familiar with using Teams, the chat function on the diagram there at number 1, the wee speech bubble, if people can use that to introduce themselves, that would be great. Also, we will be taking question and answers later on from everyone and putting them to our speakers. There may not be the opportunity to answer every question. I've just seen a question in the chat from Alex Bacon saying, should I be able to hear Gordon speaking? And the answer to that is yes. If people can't hear me, please let me know. Right, no one else. Okay, so back to the city controls here for Teams. So please ask questions in the chat function, or make any other constructive comments throughout the discussions. People's cameras have been automatically muted, and as a means of keeping down the bandwidth and trying to avoid any glitches. At the end of the meeting, you can press the leave button to leave. Can we have the next slide, please? So the webinar is being recorded, so people can refer back to it, and people who have not been able to attend on the day will be able to access after the session. Can we have the next slide, please? So basic outline of today. Me doing the welcomes and introductions, then we're going to hear from Tim Agnew, Marianne Frew and Timea Galgotzi from Highland, and then Andy Williams, Michelle Veldman and Niamh Rice from Greater Glasgow and Clyde. After those presentations, we'll do a wee bit of polling just to gather some further insights from attendees around about how we structure and the kind of function of these future events. And then we'll have the opportunity for a question and answer session. So we'll start with Highland, and then we'll have some question and answers for Glasgow. And that will be us. So without any further ado, I'm going to hand you over to Tim Agnew from Highland.
Thanks, Gordon, but it's Marianne who's going to kick us off today.
Start us off, yeah. I think Timea maybe needs a bit of help getting her camera on, and I'm not sure whether she's able to control that or not. I'll just start us off. Meantime, yeah, so my name's Mary Ann Frew. I'm an advanced practitioner with NHS Highland Specialist Personality Disorder Service. I'll hand over to Tim to introduce himself.
I'm Tim Agnew. I'm a consultant psychiatrist with the Highland Personality Disorder Service, chair or co-chair of the Scottish Personality Disorder Network.
And we also have Tamia Galgosi with us, who's a lived experience expert, but hopefully somebody will be able to help her get her camera on and be able to unmute herself as well. If we could move to the next slide. Just to introduce briefly what it is we're going to be covering in the presentation. So I'll start off kind of just briefly explaining the sort of NHS Highland context, mental health services in Highland and where the specialist personality disorder fits into that. And then I'll hand over to Tim, who'll take you through the development of the integrated care pathway, ICP, and also take you through the timeline of the personality disorder service development as well. And then hopefully Tamia will be able to share her experience of using the service as well. Okay, the next slide. There's Tamia. Oh, Tamia, do you want to introduce yourself? You got.
Yeah, sorry, just showed to me that I cannot cannot turn on because I'm not a presenter. I'm Tima Gargozzi and I'm a lived experience expert. And thank you. I'm gonna hand it back to you, Marianne.
Thanks, Tamia. Great, you got on. Okay, if we can just move on to the next slide then. And the next one. So yeah, we've just got a kind of map of the NHS Highland area here. So as you can see, it's a huge area. All this area in colour is the NHS Highland area. It's split into sort of two operational units. So that we've got the Argyll and Bute Health and Social Care Partnership at the bottom in yellow, and then all the other coloured areas, the green, orange, pink and blue, is the Highland Health and Social Care Partnership, also known as North Highland. So we might refer to it as North Highland or Highland, but the entire NHS Highland area covers both those partnerships. But if we can move on to the next slide, just to kind of recap again, that sort of pink area on the map on the left is the Highland area or North Highland area, which is the area that the personality disorder service covers. So it doesn't cover the Argyll and Bute area. And just to, I suppose, kind of give a bit of an overview of the kind of unique challenges that NHS Highland faces, and the North Highland area too, is this sort of remoteness and rurality of the area. So that pink area alone is 33% of the landmass of Scotland, with only 4.4% of the population. So, and quite a big kind of, I think about a quarter of that population then condensed into the sort of Inverness area as well. So it certainly does present quite unique challenges. You know, for example, we've had patients who have been attending our service for DBT therapy, for example, coming from Wick, right up the top, the north there, we'd have a 2-hour, 15-minute journey to get to Inverness, to get to the hospital. We quite often have to stay overnight in hospital accommodation and then travel back on their own the next day. So huge commitment from patients, you know, having to engage in the treatments within Inverness, and huge sort of, I suppose, cost to the service as well to be able to kind of meet those needs of people. Yeah, so if we can move on to the next slide. So, like you're saying, it's actually North Highland or Highland area secondary care mental health services comprises of New Craigs Hospital, so one psychiatric hospital in Inverness. There are 8 community mental health teams. We've got the mental health assessment unit, which is based within New Craigs Hospital, that will assess any sort of acute presentations and decide whether people are admitted to hospital or not. And also the mental health liaison team that are based in Raigmore Hospital, the General Hospital in Inverness. And there's more recently been the development of a primary care mental health service, which should be kind of open to referrals quite soon. So that's all of the secondary care mental health services within North Highland. And if we move on to the next slide, please. So the personality disorder service is a tier 3 integrated multidisciplinary specialist outpatient service for patients with a diagnosis of personality disorder. It sounds quite wordy, but the personality disorder service will only take referrals from secondary care services, and it's for people, you know, who have an established diagnosis of personality disorder, who maybe have been through the treatment pathway and you know, still not improving, or for people who are particularly complex or high risk. And like, just a kind of reminder again, it does serve in the area of the Highland HSCP or North Highland. In the next slide. So this is just an overview of our team, the personality disorder service team. So we've got Tim, our consultant psychiatrist. We have one advanced practitioner team lead who's also an OT, with 2 advanced practitioners who are RMNs, and 2 other practitioners who are RMNs. We've got 1 assistant practitioner, 1.5 equivalent secretaries, and we also have a 0.2 equivalent of NHS volunteers. So that's a patient who's kind of been all the way through the pathway, treatment pathway, and then has applied for a job as a volunteer within the service. Okay, and the next slide. And just in terms of the functions and what it is we do within the personality disorder service. So once, you know, a referral has been accepted, we'll assess all patients, a quite sort of lengthy assessment, kind of looking at sort of presenting current problems as well as developmental history, sort of multimodal assessment. They'll then provide the patients and their teams with the formulation and the treatment recommendations. And some of those treatment recommendations may be for secondary care services to deliver, but some of those we deliver ourselves. So there's some direct clinical care within our service too. We also provide consultation and supervision for kind of individual cases, but also to kind of wider teams, to community mental health teams as well. And we deliver sort of various training packages, such as introduction to personality disorder service, responding to distress, and just to help sort of raise awareness and education around personality disorder. So all of that, all the work that we do has been organised, informed by the integrated care pathway on the next slide. And I'm just going to hand over to Tim, who'll take you through the rest.
Thanks, Marianne. I'm really pleased to be here, and it's great to see so many people here. I think I'll just pick up from where Marianne left off and talk a wee bit about what an ICP is, and how the ICP in Highland has helped kind of put a frame and scaffolding around the service as it's developed, the specialist service, and take you through a bit of a timeline of the development of that service. Next slide, please. So if you just click all the little bullet points up, please. So what is an ICP? It's a person-centered and evidence-based framework, and it tells care providers, people using services, those close to them, what should be expected at any point along the journey of care. And that kind of setting out the stall, I think, is really, really important for any area of healthcare, but perhaps particularly when working with people with a diagnosis of personality disorder, where sometimes, you know, the frame in which they've been working with other people or in contact or interacting with other people hasn't been clear, and I think that it's a really helpful way of just making sure that everybody knows, you know, what they're doing and what they're working towards. It also allows the comparison of planned care with what was actually delivered, and that can help in thinking about service development. The one thing that this ICP kind of pays particular attention to that other ICPs perhaps don't is in as much detail, is setting out a philosophy of care, so kind of general principles and kind of specific parts to the frame around which services develop. Next slide, please. So to take you back to the kind of inception of the current ICP, there was an ICP in place for borderline personality disorder from about 2007, and that was part of the integrated care pathway work that was started by the Scottish Government at that time. and borderline personality disorder was one of 5 named conditions for which each board had to set out an integrated care pathway or develop an integrated care pathway. But by 2013, although borderline personality disorder ICP was still the only one that was working in Highland out of the 5 conditions, it was pretty clear that there was a lot of variation in approach. People in different CMHTs were getting quite different treatment pathways. Some CMHTs and sectors were still of the opinion that personality disorder wasn't really the business of community mental health teams or even mental health services. Others were using hospital a lot, others were using medication a lot. Some CMHTs were providing steps, others weren't. So there was a lot of variation, and that was between teams and within teams. Next slide, please. And if you put up all the bullet points again, thank you. So there was widespread support for reviewing and updating the ICP, and there was an initial meeting, a wide meeting of all stakeholders in March 2014. So that was primary care, secondary care, mental health services, secondary care general services, people with lived experience, all sorts of public sector and independent sector stakeholders were present. And we worked up a list of sections for the ICP, important things to focus on, and every subgroup had representation from most of those groups, importantly, people with lived experience in all of those. Once the draft documents were developed, they were sent out for very wide consultation. And there was a real desire for a bottom-up approach rather than top-down. So it was about what was there, and what was going to be helpful rather than a kind of telling people what was going to be helpful. We were listening to people to hear what was going to be helpful. Next slide, please. So these are the sections of the ICP as they stand. I think in our next review we'll probably add some sections in, but this is what was agreed at the initial stakeholders meeting, and there's a kind of chapter or section on each of these, and a subgroup worked that up for each of the subsections. Next slide, please. So the timeline of the ICP work was that in March 2014 we had our first meeting. By January 2015, the drafts were put out for broad consultation. So a huge amount of work was done in that period, and the next month the document was finalised. And by November, the electronic document with all associated resources was put on the Highland internet site. And in January 2017, after about a year, we did a survey around usability and usefulness, and it was almost overwhelmingly positive, and people found it very, very helpful. Next slide, please. So I'll talk a bit about the personality disorder service itself and how that developed within the framework of the ICP. So next slide. So until 2006, essentially most of the treatment for people with a diagnosis of personality disorder was in New Craig. There were lots of out-of-area placements. There were lots of people who were in hospital acute wards for long periods of time. And there was a structured admissions program which was designed to reduce the kind of the ineffectiveness of admissions and tried to keep things really quite focused for people with clear targets. Next slide, please. In 2007, the first cohort of people were sent to train in DBT, and that really made quite a difference. But the DBT service quickly became overloaded, and there was a real mismatch between some of the patients who were being sent for DBT who really didn't have difficulties to the level of severity that required the intensity of DBT, and they didn't do so well in DBT. Next slide, please. So STEPS was introduced across the community mental health teams, and that's a kind of slightly less intensive intervention, but with a lot of similarities, I think. And that was really helpful for people with kind of less severe problems with borderline personality disorder. Next slide, please. But the question was asked, well, what happens after stabilization occurs? And we worked together with, again, a wide range of stakeholders to develop a day service for people with personality disorder called the CAST Day Service. And that was for people who had any diagnosis of personality disorder, not just borderline personality disorder, and it was aimed to get people into a life worth living, helping them to reconnect with communities and to work towards developing their own resources to the point that they were replacing the need for mental health services with resources in their own life and communities. Next slide, please. So in 2015, as you heard, we put all this down in the ICP, and the work that we talked about was done. Next slide, please. And that allowed really a kind of explosion of work to happen. So in 2015, lots of things happened. The Personality Disorder Service brought in a standardized multimodal assessment, which allowed anyone to do the assessments because they were standardized, and an MDT could contribute to that assessment. Referrals were accepted from secondary care mental health services for reasons of complexity, severity, or lack of treatment response, and the dedicated staffing started to develop. Other functions like training and education and consultation and supervision also started to develop. Next slide, please. Since 2015, all of the developments happened within the framework of the ICP, and important principles were matched care and phase-based care. There were others like trauma-informed care and the kind of general principles, but we don't really have time to go into those now. So it's worth just holding in mind the matched care and phase-based care approach. And the framework allowed us to identify gaps in provision and what function needed to be fulfilled for people. Next slide, please. The phase-based approach, I mean, lots of you will have heard about this. The version of this that we use is Livesey's version, but Marshall Linehan, Judith Herman, Pierre Janet, back in the 19th century, all of these people talked about the same phase-based approach in essence. And we just find that the first one's a bit more flexible for us. Next slide, please. So since 2015, we've had further developments in terms of what we're offering. 2016, we have a support and self-management group, which is a short, rapid access, skills-based psychoeducation group. In 2017, we introduced a decider across the whole area. We've trained to date, before COVID, about 1,400 people, and that's about a language for skills and self-management. 2018, we developed a psychoeducational post-diagnosis group for patients who've been given a diagnosis of personality disorder. 2019, we provided consultation and support for the launching of a decider graduate group, which is led by people who have been within services and have gone through the decider, but it's not an NHS intervention. We just provide support for that. 2020, we moved to remote delivery, which of course is important for remote and rural aspect of things. 2021, we started GROW, which is Group Radical Openness, which is an intervention designed to help people who've got over control problems as opposed to the under control problems that you often see in conditions like borderline personality disorder. 2022, that's just now, and we're developing a STEPS collaborative. So that's kind of all CMHTs kind of put therapist or facilitator time into this STEPS collaborative, and as a result, all of the patients in that CMHT can access that. So that will be done remotely, and given the size of Highland, you'll see why that would be necessary. That kind of joint working across CMHTs, so the remote working's really helped us there. 2022, we've started and expanded the function of consultation. We've opened it now to all CMHTs in the mental health assessment unit. So that's now monthly regular consultation with a reflective space, and also a bit of guidance with regard to specific questions around the ICP and how it should be applied. And in 2022, we're starting to develop a friends and family group, or that's what we're calling it at the moment, which will be a kind of psychoeducational group for people who have loved ones with diagnosis of personality disorder. Next slide, please. These are some of the things that are really important for remote and rural working, and the consultation function, so supporting teams to do the work, and that can be informal consultation, a phone call to one of the members of the team. It can be group consultation like I've talked about for the CMHTs, the mental health assessment unit, or it can be specific case consultation, so people can request that for specific people that they're working with. The Decider network supports the decider skills package across Highland, and that's in third sector independent, other public services as well as health. Remote working, so that's kind of teams near me, that kind of thing. That's really been beneficial. And the STEPS collaborative that I've talked about. Next slide, please. And we're over to Mia.
Yes, thank you so much, Tim. So this was my kind of experience to go through the services from the very beginning. First, I've been referred to the New Place Hospital for assessment by my GP, and then from there to refer to the self-management group. But in that stage and in the state I was, the self-management group really did not cover for me the key issues and really wasn't focused on the challenges of the personality disorder. And it just felt like it lacked really what I needed at that point. After that, there was a little of wait and refer to staffs, what I find very useful. And I think the first time I could meet with people who was like struggling with the same things as me, and that was also very beneficial for me. But again, it fell short, and it felt like it didn't really cover all the decider skills, and it didn't really click with me. I couldn't really use it at that point. And after just a very short waiting time I got in CAS, and I mean, I find CAS Whittle just supporting and just using the decider skills, meeting with people, again, the same issues, same BPD. So I find that just really amazing. And for the first time, I experienced person-centered support, so the goal setting and finding motivation, just looking through others' experience. That was really just amazing. Can I have the next slide, please? Yes, and just a little bit of feedback that I think there should be elements and parts of the CAS integrated to earlier support, for example, to staffs. I feel like that would be so positive for a lot of people, especially that there is sometimes like quite a long waiting time between services. And also it was hard to integrate self-management skills learned in supporting self-management group when it was the first line of support. Again, it felt, I feel like, very little for people with personality disorder to receive that support, and that was, of course, the first line of support. And yes, at that point, I think me and all others really lacked insight of the disorder and what we really need. Yes, and that's me. Thank you very much. And I'm going to hand it over to the next speaker.
Thank you so much, Timia and the team and Highland. That's fantastic. Look at all the applause that's coming, and I see people have already started to put in some questions in the chat. So please, we'll encourage people to continue to do that, and we'll try and respond to as many as we can during the session today. So I'll move along quickly. We're packing a lot in today, but I'm going to shift our focus to Greater Glasgow and Clyde. So we're shifting from a large geographical area, remote and rural issues, to a large urban health board. And so we'll be telling a slightly different story, myself and my colleagues from GG&C. My job is to start with a bit of an overview of our development towards a pathway, a more coherent pathway in Greater Glasgow and Clyde. And I hope there'll be something useful and generalisable out of it, whichever area of Scotland you come from. That's what's the aim, is to try and kind of think about what are some of the ingredients that have helped to bring our services towards a more integrated pathway. So something about the process and the drivers for change. Have the next slide. So not to be outdone, I've also done a map just to show that it's a much smaller geographical area, but a hugely concentrated area in terms of the population size for Greater Glasgow and Clyde. So the green blob there is the Glasgow city bit, and all the other colours around about are the other elements, the other HSCPs that go together to make up this large health board. So we've got Eastern Bartonshire, Western Bartonshire, Inverclyde, Renfrewshire and East Renfrewshire. all going together to make up GG&C. Next slide. And just to get across, I guess, the size and complexity of our services, we're talking a huge population, and of course, in response to that, a large amount of mental health services organised into a lot of different systems. So we've got 18 CMHTs across these HSCPs. We've got admission wards on 6 different sites. We've got crisis teams and intensive home treatment teams. Mental health assessment units are a relatively recent development, and out of hours out of hours CPN services. So that's just some elements of all the healthcare that covers that area. I'm going to put up the next slide. You have to forgive me for the madness and the colour of this slide, but this was my attempt to try and represent something of the complexity of the different services we had in place prior to our efforts around 2018 to start bringing this together into some kind of more coherent pathway. So I've deliberately kept it sort of colourful and messy, and it doesn't represent everything. I haven't managed to put onto this map quite a few services, and I haven't managed to put on all the complicated interfaces between these services and pathways between these services. But just to highlight a few things on this picture, within the big yellow circle of secondary mental health care, we've always had CMHTs, you know, our 18 CMHTs who have done things like attempt to do assessment, diagnosis and formulation in a helpful way, have delivered things like psychoeducation, have worked on crisis plans. But you can imagine across all the different HSCPs and the different local community teams that, a bit like Tim was saying, this has looked different, variable from place to place. So all those functions were there, but they didn't have an organising sort of pathway or structure. I've highlighted at the top of the diagram that some of our local HSCPs already had sort of beginnings of, or quite well established sort of local pathways around working with people with a diagnosis of personality disorder. But these again didn't relate to each other or didn't relate to the whole. Over to the right-hand side, I've tried to represent some of the functions that clinical psychology had developed over time. So we had pockets of development in terms of STEPS programs. There was a DBT pilot which was established and already being evaluated, and Michelle's going to speak to that in a little bit more detail. There was already delivery of things like a package of emotional coping skills which had been developed, but again without a sort of overarching pathway to hold this all together, and it was delivered at different rates, different amounts in different areas. And over towards the left, you'll see within psychotherapy services, there was also local developments of things like an MBT service. So if you look at this whole picture, we've got good bits here. We've got evidence-based therapies like DBT and MBT and STEPS. We've got CMHTs trying to do a good job of the kind of core functions of secondary mental health care. We also have a super specialist bit over on the far left of the personality disorder and homeless team, which is where I work. But again, none of this sort of linked together in a sort of coherent way. So if you put up the next slide. Some of the catalysts for change were things like taking an interest in the amount of cost really to a service of working with people with a diagnosis of personality disorder, if that's not well organised and well structured. But there's good evidence out there around sort of cost savings that can be made in terms of use of bed days and use of out of hours and crisis services if you get access to treatment and therapies right. So these arguments are out there, and we can utilise those to kind of make an argument. And that's what happened in GG&C, that there was a kind of will to make an argument that if we improve access to care and therapies, we might actually save the health board money. These are the kind of arguments that managers like. And it came along at the time when there was also a bit of funding into mental health staffing, the Action 15 monies. So what you need, I guess I put it at the bottom there, is the strong leadership. We had, I guess, senior managers, clinical managers and operational managers who had a real appetite and interest in trying to make change here into something that was that made better sense for the health board, but at the root of it made better sense for the person coming into services, no matter where they showed up across this huge complex system, that they got access to something coherent and consistent. And I think we also worked with the enthusiasm and expertise that developed in these little pockets. So we had the DBT pilot, we had the steps, we had the MBT developments, and we had staff there with a real interest and enthusiasm for change. Next slide, please. So implementing change, I guess a few ideas here that might be important and for other areas to consider if you're working on a journey towards developing pathways. I guess there's something incredibly important about writing it into the strategy at the sort of health board level. So we have these several health and social care partnerships, but there's a central mental health strategy that stretches across them in GG&C. And we, on the back of that, into place came a structure, a mechanism for kind of keeping an eye on our plans towards development of a more coherent pathway. So an implementation steering group. Alongside that, there was a role for a clinical lead for personality disorder. And feeding into all of this was an ambition to have lived experience input to all aspects of this development. We had a slightly tricky situation in that there was a push for change to happen quickly. So there was a demand for pushing for change and for measuring implementation and change. But developing a good model for lived experience input that's meaningful takes some time. So that there's been a bit of a kind of process of trying to get that into place that in a way that feeds in meaningfully to the whole system. And underlying our whole system, we've worked on a kind of model that we've called coordinated clinical care, which really contains our principles for good care across the whole piece. And one of our aims was to make that not fixed on one model of therapy, but to draw on all the models of therapy that we have in GG&C. Next slide. I'm sorry. Push forward quickly because we've got a lot to fit in. This is just to give you an idea of what our current model now looks like. So we've got the light blue area, which is our coordinated clinical care within secondary care mental health that sits around everything that we do and includes all the functions that happen within CMHT and wards. And then you'll see a sort of stepped matched care model of the different therapies that were on our map to start with, but just now in a more organised format. And with our pre-existing access to other therapy strands as well, and psychotherapy and clinical psychology. And the last slide for me. So just a couple of learning points out of this whole process. I guess strategic and managerial support is key to this, to have drivers to push this forward, to have a coherent kind of set of principles that underlie everything that you're doing, to keep conversations going and to be willing to discuss and cooperate and compromise across all of our services, not getting stuck in our professional or theoretical silos and keeping the conversations going. And a recognition that traction and embedding of any change takes time. I will stop and pass over to you, Lee, please.
Thanks, Andy. If I can just pop on to the next slide. Good morning, everyone. My name's Niamh Rice. I'm a consultant clinical psychologist and team lead in the Psychological Therapies Group Service here in GG&C. And I'm just going to talk a wee bit this morning about how our service is contributing to the BPD pathway. Next slide, please. So the Psychological Therapies Group Service was identified by the Effective and Efficient Community Services Workstream as a viable option to increase access to psychological group theory in adherence with the matrix. So really the aim of the service is to increase availability and predictability of psychological therapy group provision for our secondary care adult mental health population. So a partnership model was initially agreed whereby the Psychological Therapies Group Service sits as an adjunct to the 18 CMHTs and works in partnership with our CMHT colleagues to provide group therapy, as well as expanding and supporting any existing group provision that exists within the teams. Next slide, please. So initially the service was designed and developed during 2019 into 2020, so those hard to remember pre-pandemic times, but we launched in January 2021. So we launched really during the pandemic and the height of the restrictions. And initially the service launched with 2 group programs. So we started off with behavioural activation and emotional coping skills. And of course, all of this was digitally delivered. So gradually over the past year and a half, we've expanded our roster. So now we have 6 group programs, that's including STEPS, the Unified Protocol, Survive and Thrive, and ACT for long-term physical health conditions. So for the purpose of this morning, the 2 currently available group programs that we have that explicitly contribute to the BPD pathway are ECS and STEPS. Next slide, please. So I'll just say a little bit about ECS before going on to STEPS. So this is a transdiagnostic treatment program for individuals with emotional dysregulation. The Emotional Coping Skills Group Manual that was used was developed by Isabel Clark and is used across NHS GGNC with her permission and based on the Marshall Linehan Skills Training Manual for treating individuals with borderline personality disorder. So the programme covers a range of topics, focusing on emotion regulation, distress tolerance, mindfulness, and interpersonal effectiveness. It's an 8-session programme, but in the service we've added an extra introductory session, really to support orientating participants to a digital platform and to online etiquette, and just to support people really into coming into a group that's delivered in this way. So the group is delivered weekly. Each session lasts 90 minutes, and there's 2 facilitators who take each session. Next slide, please. So in the first year of operation, 2021, we delivered 15 cohorts. We had a maximum number of participants in each cohort set to 10, with the aim of commencing with a minimum number of about 8 attendees. So in the first year, we had capacity to offer 150 patients a place within these cohorts. Now in the second year of operations, so about halfway through, but we're programmed to offer and run 26 cohorts. With some learning from last year, we've increased our maximum number. So we're now able to take in 12 participants to each group, but we've kept that minimum number, so still commencing with 8 attendees. So this year, with our plan to run 26 cohorts, we should be able to offer spaces to 312 individuals. Next slide, please. So for STEPS then, as many of you are aware and has been mentioned previously, is a manualised group programme for individuals with a diagnosis of BPD. So the programme covers psychoeducation, CBT strategies and skills training with a systems component. So it really involves that idea of a reinforcement team, so supporting the system around the individual. This is a much longer intervention, so it's 20 sessions. But again, we've added in that extra introductory session just to support individuals in joining an online group. This again is delivered weekly. The sessions are slightly longer, so they're 2-hour sessions, but again delivered by 2 facilitators. Next slide, please. So last year, we delivered 5 STEPS cohorts with a maximum of 12 and a minimum of 10 attendees. So last year we were able to support 60 individuals in engaging with this group intervention. This year now we will be delivering 8 cohorts, so hopefully we're going to be able to support up to 96 individuals in moving through this group intervention. Next slide, please. So in terms of outcome measures, I won't go into these in any detail just for the purposes of time, but we take pre and post measures for both ECS and STEPS. So we do quantitative and qualitative measures. For STEPS, we also have the session by session best form. So we're gathering data throughout those 20 weeks with STEPS as well. And at the end of all cohorts, we have a session just to gather some qualitative feedback. So as you can imagine, we have a lot of data amassing, both quantitative and qualitative. So really we're putting our mind very strongly now to developing our strategy around how do we really begin interrogating and using this data to inform service development, and are awaiting the appointment of some assistant psychologists to support with this task. Next slide, please. So a wee initial look just at some of our data, just very briefly. Between January 21 and January this year, there were 16 ECS cohorts, of which 55 people completed pre and post measures. So if you look at the graph on the right, there's 3 different outcome measures that I'll talk to. So the first is the core, which provides an overall measure of distress for individuals. And we have the mental health confidence scale, measuring an individual's overall confidence in managing their mental health symptoms. And the Living with My Emotions questionnaire. And that really shows us, or gives us an indication as to an individual's ability to confront or tolerate challenging emotions. So the graph on the right indicates statistically significant change for these 55 individuals. So we can see from the core a statistically significant reduction in distress. The mental health confidence scale, we're seeing a significant increase in confidence, and equally a statistically significant increase in a person's ability to confront and tolerate their challenging emotions. But again, this is just for the 16 ECS cohorts between January last year and this year. Next slide, please. A little bit of qualitative feedback. Again, these are just some of the strands that I've kind of pulled out. While we see a lot of apprehension about joining a group intervention, a lot of the feedback that we get is actually how valuable it is to be with individuals with shared experience. So a lot about just feeling that real support network, realising that how they were feeling was normal, speaking to people who had experienced something similar. In terms of what could be improved, thinking around follow-up, thinking around what happens after groups, and thinking about paperwork being converted into a digital format as well. Next slide, please. I think advantages and disadvantages between digital delivery. So lots of themes coming out about travel costs, being able to engage in this type of group psychological therapy intervention while at home and comfortable. A lot of people talking about maybe if it were face-to-face, probably potentially not attending if it was a face-to-face group, but feeling much more able to still kind of log in and join, given that the service was digital. Equally then, main disadvantages being digital, those kind of technology issues which we all face, but also something around this less social interaction and potentially not as easy sometimes to contribute and be involved. Next slide, please. So I'm pushing my time here, so very briefly, future plans, really just to try and increase capacity, trying to increase what we can offer in line with demand from the 18 CMHTs, trying to be able to support in terms of co-facilitation. So as a service, trying to be able to offer all the facilitation, including the reinforcer role, rather than requesting and needing that to come also from CMHTs. We're bringing in the Stairways programme, which is a graduate programme for individuals who have moved through the STEPS intervention, and really, as I said, to fully utilise our service user feedback. Next slide, please. So just in brief, we're a health board-wide service designed to promote and provide evidence-based psychological group therapy as a viable treatment option to our secondary care population. And the ways in which we've been contributing to the BPD pathway at the moment are through our ECS group cohorts and our STEPS groups. Next slide, please. So that's me. I'll hand over to Michelle.
Thanks, Niamh. Next slide, please. Thanks everyone for your time. I'm going to talk as part of GGNC about the small therapy team that delivers dialectical behaviours therapy, just to help understand the context of the range of services that's available and the differences in services. Next slide, please. I'm the clinical lead for the dialectical behavior therapy service in GGNC, and that's a small therapy team with a group of DBT therapists now. It's around 4.7 whole-time equivalents, and just to give us an idea about the size of it. We started as a pilot project in 2015, early 2016, really responding to a voice of service users. The time was right. Evidence-based therapies were more embedded in services everywhere, and an organization that was willing to support. This is a therapy that delivers a more intensive therapy with smaller numbers, so that aim to change the trajectory of people's lives, of a smaller volume of people using services. And to guide us, we've used implementation science and that question of how do we make science, evidence-based therapy work in the real world. Next slide, please. Just a quick overview of the implementation drivers that guided us. It's to look at organizational support, how the organization is willing and curious to support, appropriate leadership and credible leaders who can influence strategy and steer in a certain direction, and then the competency of the actual therapy delivery, how we recruit, train and support staff to deliver a high quality service. So those three legs of the triangle has been very much in our minds over the last 5-6 years developing the DBT service. Next slide, please. Also, just very quickly, the stages of implementation, just to talk you through that for people here who are thinking about implementing evidence-based therapies and the different stages and how things can be framed. Exploration stage, that looking into options, what's needed, what's available, what's the evidence base. Installation is where in the organization, what processes do we need and what training is needed. Initial implementation can be around setting up a pilot to tease out different things and to look at feasibility. Full implementation for the DBT service is that sort of continuing with confidence to consolidate the service in the bigger network. Innovation would be once planned and delivered a service to see what else is needed in Glasgow, questions around expansion and what can we do differently. And then always with services in our service in NHS is how do we keep this sustainable and a high quality. So those stages of implementation has really guided us as well. Next slide, please. Just a question of what we need from an organization for people here thinking how to influence. Is the organization to be willing to support things differently in the sort of exploring stage, and to commit to the long process of it, that it's not making a decision and 6 months later there's a consolidated service. It's a long process, as the other speakers have talked about their services as well, that senior clinicians are leading at a strategic level, have that influence, that we understand it's all about relationships, it's all about trusting and getting on with colleagues, and also understanding that there's need for compromise, that people invest in different things, and that there are truths on both sides. So that guiding the organization around some of these points we found very useful. Next slide, please. Just to give you a quick idea of a full DBT program, which is what we deliver. I don't know if you can see that slide. It's very small typing, but just 1, 2, and 3 is the reason we here. It's a direct clinical work that we do with people who require this service. So skills group helps people to acquire new skills. Individual therapy is around motivating people to fully engage in it, to tailor things around that. And the telephone coaching is to generalize it in their lives. The other two aspects is sorry, can we just go back? I'm just, the number 4 is the developing staff and the strand of the service that holds the team and that holds governance in the team. And 5 is, I'm going to talk a bit more about it, how we structure the environment and influence the wider mental health network around liaison, training, supervision and consultancy and all our work around that. Next slide, please. If we move on maybe to the next one, I'm just trying to cut time here. I'm very aware of our time. Thanks. Just a very quick idea to give us a sense of the long process. I'm not going to go into the details, but the top is months, and just that the official start, the blue arrows, is the 12 months we actually delivered a therapy to people who require the service. So that's 2-year period. The yellow is delivering DBT and the orange is delivering STEPS. So in a 2-year period of starting a pilot, we've treated 14 people. Just to help us understand, when we begin to look at the more intensive therapies, how much commitment and appetite we require for establishing that before we get a sense that it is consolidated and working with groups of people. Next slide, please. Just in terms of our evaluation, consistent outcomes over the last few years that we managed to engage people who have more severe and complex problems, and that there's a reduction in hospital and unscheduled care use, and people use it differently, a reduction in risk and other symptoms, that there's a general sense of difficult emotions are tolerated more effectively and therefore some reduction in risk, and that people are more able to engage in their lives around other activities such as work and education. Next slide, please. I give you a minute to read that. That's our patient, some of the patient feedback that we get regularly. And next slide, please. What we've learned is that we were wanting to see that it's feasible that we can work within existing structures, that we sit next to secondary care and get referrals from that, and that we can engage severe complex patients. It takes time to learn and implement, as I've said, but liaise with a whole range of people and hearing what others think, which directions the service should develop into. That evaluation of such a service is difficult, but possible, and to spend time planning for that. It requires organizational commitment through thick and thin. The team, then therapy team that has credibility, develop a larger role in the wider network and strategy, involve people with lived experience more from the start, and always getting other input from external resources nationally, and so to continue to bolster robustness. Next slide. Just the last few points is how important it is to have ring-fenced time, to have people who aren't just borrowing time from their standard jobs, to build on a group of experienced and trained staff, that group of staff develops credibility and can contribute very significantly to the organization with support of staff in general, that with a small group of staff like that, one gets a high adherence of evidence-based intervention and that leads to better outcomes. And that a therapy service like this can then have the credibility to contribute to strategic thinking in the organization. That's me. I'll hand back to Gordon. Thank you very much for listening.
Thanks very much to all the speakers. That's fantastic. Huge amount of information in there, and some really excellent work being done across both boards. I think there's lots of food for thought there. There's lots of stuff that we can implement. Just a quick word to everybody on the kind of timings. Inevitably, we're running over a wee bit. I intend to do this poll section just now, and then we will go on to have some live question and answers. But everybody's questions will be answered and sent out to people on the distribution list. So these are polls to help us kind of structure how things go on. I've just missed the first one. They're in the chat though. So question 2, all the questions are in the chat. I don't think I need to necessarily read them out. If people can please look in the chat and just click on the answers. These will help us to structure how the future learning system events go. I think maybe note to self, add in an extra 5 minutes for polls. However, we've got, are there more coming up? I think, do we have 6 questions? Yes, we do. That's the final one. Okay, so the 6 are there in chat. I think maybe while people complete that, would it be efficient use of our time just to head over to some of the question and answers for Highland? Gives Glasgow a chance to react to some of the questions that have been asked. So I'll duck out the camera and over to you, Tim.
Thanks, Gordon. Okay, I'll just go through the questions in the order that I've got them. First one is, what would be the rationale as to whether to offer decider or steps group? Are the thoughts or data which inform the most suitable intervention for an individual? I think essentially, if someone has been given a diagnosis of borderline personality disorder, steps is an evidence-based treatment for that condition and should be offered. That's if DBT is not appropriate, which is also an evidence-based treatment. Obviously, there are others, but these are the 2 evidence-based treatments we have in Highland. So if the diagnosis has been made, it should be an offer of steps. But if the person has problems with emotion regulation and a diagnosis of personality disorder that doesn't meet full criteria for borderline personality disorder, then decider can be offered. And the decider was introduced in Highland as a quality improvement exercise. So most people in mental health services have problems with emotion regulation and or self-management. So I don't think there's many people would argue that skills training and that shouldn't be part and parcel of our service delivery. But there was a large variance in how that was done and the quality of that. So that's what the decider's about. And it actually has a lot of similarities to the emotional coping skills group that we've heard our Glasgow colleagues talk about. So that's the first question. Second one, why is the service not available in Argyll and Bute? Simple answer there. Argyll and Bute get a slice of money for all the money that comes from the government, and North Highland gets a slice. Argyll and Bute spent theirs on something else. Simple answer. Number 3, I noticed that there's no psychologist integrated into the team. Is this something you're considering in the future? We have had psychologists in the past as part of the DBT service. We do have 1 clinical psychologist at the moment. We work in a very team-based way, so it's likely that any clinical psychologist would just be working as another member of the team. If someone came along and said, here's some clinical psychology time, would be delighted to take it. And just have that person working as an integrated part of the team. So I think we'd be delighted with that if someone came along and gave us some resource. I appreciate how beneficial remote access to treatment will be in Highland, but I also appreciate there are huge gains in peer support in some groups. Is this a noted issue? So we have looked at all of our strands pre and post COVID. What we've seen is that the outcomes of patient completers are more or less the same. The attendance of patients who are in long groups, so that's DBT in the day service, who a year and 36 weeks is actually improved when it's delivered remotely. But the short groups, things like the post-diagnosis group and the support and self-management group, the attendance is significantly worse. So, you know, you could hypothesize as to why that might be, but that's something that we've seen. So there are pros and cons to it, I suppose, is the answer. Our issue with running groups face-to-face is the face mask requirement. And the difficulty in people accessing the whole non-verbal, I suppose, emotional communication that masks take out of the picture. So we actually feel that it's more effective. The communication is more effective when you can see someone's face online than in a room and everyone's got masks on. When the masks go, we would aim to run some kind of blended service, I think, to keep the remote and rural aspect. Because some people are having to stay overnight, or were having to stay overnight to access groups. So they're traveling 3 or 4 hours, staying overnight, going to the group, and then traveling 3 or 4 hours home, sometimes for a year. And that's one heck of a commitment, really. So we've started to think about this, and it might be something along the lines of the group meets face to face once a month, and the other 3 weeks they meet remotely. We don't know. We need to you know, work with the folk in our service to work out what's best, but that's been some of the feedback we've got on that. Next one, second last one. Can I ask, Highland, what extra training your advanced practitioners have done? So I think that a wide range of trainers are training. So one of our advanced practitioners, IPT supervisor, there's been group radical openness training, decider trainers, licensed trainers training, steps training, prolonged exposure training, various supervisor trainings, trauma trainings, and training in the assessment process. So really quite a wide range of trainings, both within the service and out with. And the final one, just wondered about education and development of practitioners within the service and out with and within general service provision. We do have an ongoing programme of education that's kind of previously was delivered in person. It's now being delivered or able to be delivered remotely. There was a TURAS module that's still on TURAS but will be updated, a kind of electronic module that predated COVID. And we offer training really on a kind of open basis. We run introduction to personality disorder training several times a year, and that's just put open to anyone. But we also will respond to specific requests for training. So, for example, we train all of the police probationers who are coming through. We've trained all of the frontline police officers here. We train all the mental health officers. We train various specialist registrar groups in psychiatric training across the country. We are currently discussing training with the perinatal mental health team and the community midwives and health visitors and so on that work with them. So that's just some examples, but we're happy to be flexible on that, because that serves a function really in terms of the remote and rural working and getting people upskilled, changing attitudes and improving knowledge, so that across the board people are delivering as high quality a service as they can for this group of people. Okay, that's all the questions I have. Hopefully that's answered some of those adequately. I'll pass you back to Gordon, or is it across to Andy and Michelle?
I think that's fine. We'd just go straight over to Greater Glasgow and Clyde.
I think I've managed to respond to a few of the questions in the chat. So should we maybe just pick out one or two?
I'm just seeing a couple of questions coming through. I've lost it here now, but about aftercare, after therapy. I'm just reading this, that people who have had a therapy require aftercare. I think we have definitely in Glasgow and Highland will be the same, have that feedback in all our services about that, what is after therapy if people feel they've had adequate of that particular therapy. And we are developing definitely in the DBT service, and I know the group therapy service are thinking of further support after steps, but in the DBT therapy service, a graduate group, and with really two-tonged approach around helping people to continue to use these skills and for that peer support there, and also to involve people then with further service design. But absolutely agree that that is something people talk about a lot after therapy.
Absolutely, I think we hear that a lot as well, Michelle. I think that question, you know, especially after a group intervention like STEPS, which is so intensive and it's weekly for us for 21 weeks. And I guess one of the ways we're trying to respond, as you said, is to bring in the Stairways programme, which will offer as a rolling programme just throughout the year. So graduates of the STEPS programme can join the Stairways group or cohort at any point. They don't need to wait for it to start. I guess as an adjunct service, so the psychological therapies group service is in addition to the CMHT team kind of holding and providing that kind of case management for individuals. So I guess we also have a role in kind of liaising and kind of working with teams as individuals move back into the care of their teams.
Great. And I see there's a question about evaluation across all of the psychological therapies in the BPD pathway. And just to say, yes, we do have a plan to sort of standardise some of our measures across the different strands so that we're using the same outcome measures across MBT and DBT and some similar ones in STEPS, and slightly different choices depending on the, and you've heard from Niamh about the emotional coping skills as well. So yes, we've got a sort of system now in place, a better system to try and standardise some of our evaluation methods across all the bits of the pathway.
And I think it'll allow us to also evaluate face-to-face versus kind of digital delivery as well to ensure that that effectiveness is being maintained.
Yeah. And there was a question about supervision as well, I think. I suppose just to say that all of these specialist therapies are delivered with the right amount, the right sort of supervision in place. They're all developed as per sort of guidance, really, with clear clinical supervision in place to help maintain the fidelity of the delivery of the models. And there was an interesting question about older adults, particularly in GG and C, I think I picked up, and whether we maybe don't recognise traits or diagnosis of personality disorder in older adults, and whether people have access to services. I think I've heard, we discussed it at the BPD steering group, and we've heard different accounts from different colleagues in older adults. So some saying it's not a very common presentation, and others saying they're seeing an increase actually in presentation of people in the older adult age groups. So it's one of our ambitions to adapt the training programme that we're running for the adult services to some of the other care groups, including older adults. So there's work to do there to maybe slightly adapt the training for people in that older age group, because there probably are some slight differences in presentation and ways of working. There's not a huge amount of research around that as far as I'm aware. So I think it's an interesting area that will have to be guided by our older adult colleagues on how to adapt that training. I guess, Gordon, maybe we have run a fair bit over, so I wonder if any of the other questions we make our guarantee to have a more thoughtful sort of written response to all the questions that have come up and where we haven't covered everything.
Absolutely, Andy, and I think that will be a feature for all of these events. That will all of the questions will be answered and sent out to everyone. But I think it's really good to have that kind of live response as well. And I'd just like to thank all the speakers for coming along today. I think it was a huge amount of information. I think it was very well presented to us. I think there's lots of learning from today. Thanks very much to all of the attendees for coming along. I think we had about 170, over 170 people at some points today. I think that's fantastic. And the fact that we've still got so many people hanging on, after our designated closing time, which probably leads to one of the questions round about timing. I think we could easily fill an extra 15 minutes in these sessions. We're conscious of everybody's time, but I think we might look to extend the next one a bit, so we've got a bit more time and we can have more of the interaction. Our next event will be on the 9th of August, and that's going to be our first workshop. It's going to look at often overlooked, underserved groups in terms of personality disorder. So there'll be stuff getting sent out in the mailing list to that and advertised through our usual channels. Please pass on to any of your colleagues, anyone that might be interested in attending any future events. But at 12:15, I think we'll call it quits on this. Thanks very much for everyone's input today.